Everybody, Dr. Brace here for Facial Plastics Friday, and I'm just coming home from Guelph General Hospital after finishing a long week. And what I want to talk about was on Sunday of last weekend, I ended up doing a pretty big facial reconstruction case for a poor woman who fell and fractured her face. And I want to talk about the approaches that we use to the facial skeleton. So in this particular case, this patient broke her lateral orbital rim, so this bone right here, broke her zygomatic arch, this bone there, and it wasn't just broken, but it was comminuted, so in 3 pieces. Then broke the cheekbone in here and the cheekbone out there, and the eye socket, so the floor of her eye socket, and her mandible or her jaw. And so quite an extensive set of fractures on the right side of her face, which meant that we had to approach them multiple different ways. And so to approach a zygomatic arch fracture, there's really kind of two options if you're going to operate on that. One would be a little incision in the hairline where we go down onto the chewing muscle. You can actually see the edge of my chewing muscle there. That's the temporalis. If you go down onto the temporalis muscle, follow its lining all the way down, you can pop underneath that bone with a little instrument and you can push out the fracture. That's called a Gillies approach. And you can do that kind of without putting plates and screws on it. But if it's really crunched, if it's really broken, you have to make a bicoronal incision to get to it. So that involves an incision across the head where you peel down the forehead, and that allows you to expose this. Now, you may ask yourself, like, why on earth would you do that? Why don't you just cut right above it? Your facial nerve, the nerve that comes up, the frontal branch anyway, that comes up to your forehead, lets you raise your eyebrows, that travels right over top of that bone. And so you have to get underneath that bone, underneath that nerve on top of that bone to protect that nerve to prevent from creating a paralyzed eyebrow. So the safest way with the best access is what we call a bicoronal incision, which is across the head. You lift everything down, it exposes this beautifully, and you can get plates and screws on it. So for this case on Sunday, we used that approach to the orbital rim and to the cheekbone. And then in the cheek itself, it's mostly thin bone, almost like eggshell in the front part of your maxilla, which is the front part of your sinus, but right along your nose here and right along the side here, we call that the medial and the lateral buttress. And when you chew and clench, the forces of mastication or of chewing get absorbed by those thicker bones or those buttresses. And in the case where they're both fractured, you have to fix them or else the teeth will move. And so in this case, we went through the mouth. So if you lift up your lip and look right above your teeth, we call that the upper buccal sulcus or the gingiva buccal sulcus. You can make an incision in there, get right on the bone, and again, safely, without hurting any nerves, lift all the soft tissue off the cheek, access the fractures, put the plates and screws in. And then there's the eyelid or the orbital floor. How do you get to the bottom of your eye socket without hurting your eye or hurting anything? Well, there's a couple different approaches. One would be just through the skin. You can do a transcutaneous or a mid-lid incision and go right in and lift up the eye and put the orbital floor plate or the reconstruction plate in there, whatever you're going to use. But what I like to do is try to keep it scarless. We pull the eye down and we make an incision inside the conjunctiva, right in that pink stuff, and go transconjunctival. And so for this patient, we were able to go scarless essentially through the inside of the eyelid, through the inside of the mouth, and inside the hair. There'll be a scar there, but hidden by the hair, to be able to plate the orbital floor, the orbital rim, the zygomatic arch, the medial buttress, the lateral buttress. And those are the approaches to facial fractures. And so some people don't know that I do facial fracture surgery, but here at Guelph General Hospital, that's part of my role as a facial plastic surgeon, is fixing craniofacial trauma or maxillofacial trauma. And it's not something that happens often, thank goodness. And most of the time when fractures happen, you don't need to operate on them. But when you do need to operate, it tends to be a pretty big surgery. And so that's the reconstructive part to facial plastic and reconstructive surgery, at least one of them. The other part of my practice would be skin cancer reconstruction. And that is on top of the cosmetic work that we do. So I tell people that being a reconstructive surgeon makes me a better cosmetic surgeon, but being a cosmetic surgeon makes me a better reconstructive surgeon, because you can apply principles from both when you're dealing with moving tissues around the face and changing the way something looks, either restoring it or from trauma or from age, or just trying to fix a fracture or a wound for like a laceration. So that's Facial Plastics Friday. Send us your questions if you have any about facial plastic surgery, and we'll see you guys next week.